right now. You're both. Good morning, everyone. My name is Peter Constantino. I'm the Executive Director of Pennsylvania MGMA, and welcome to our peer-to-peer collaborative session of our 2020 virtual conference. I'd like to thank our session sponsor, Curtis Bay Medical Waste Services, for sponsoring this event and also for being a participant in our virtual exhibit hall. I remind each of you to please go to our virtual exhibit hall and interact with our sponsors. It is important that we show them our appreciation for their financial support and their support overall in bringing you this virtual conference. We hope that we can meet in person next year at some point in time, but we will get through this year first. It is my pleasure to welcome our moderators. From Dermatology LTD is Paul Brewer. Paul, if you'd at least wave so everybody can see you if they don't see your name, thank you. From Evangelical Community Hospital, Holly Dieter. Holly is also the past president of Pennsylvania MGMA. From WellSpan Medical Group, David Regan. And David is a past president of the Pennsylvania MGMA. And from Academic Urology of Pennsylvania, Marianne Thompson. Thank you, Marianne. And from the Mount Nittany Physician Group, Jonathan Rose. So I appreciate them. What we're going to do, we originally were going to go into breakout rooms, but we thought that this may work out better if we're all together and participating in this discussion. So this is a freewheeling, if you wish, discussion on 4 topics that we have selected for this year. We will spend 10 minutes on each topic. I don't want this to sound like a presidential debate. Each moderator will be given, though, 10 minutes to moderate the discussion on a topic that they will lead. I will offer a 2-minute warning before we go to the next topic. Please feel free to unmute yourselves, speak freely. This is a chance for you to share what's worked, what hasn't worked, maybe even some of the things that you feel that you have challenges on within the specific topic. So our first topic is going to be staffing, and it'll be led by CMPE of Dermatology LTD, Paul Brewer. Paul?
Thank you, Peter, and welcome everybody. I thought that I would focus the time as we talk about staffing on specific issues maybe that we've all encountered to one degree or another as a result of COVID-19. So to get things started, I thought maybe just a focus on the Family First Coronavirus Response Act might be interesting. And we did hear an in-depth overview of that yesterday by George. And I'm sure you're all familiar with it, but I thought just to get things started, I would quickly share our experience and then open it up to any thoughts or experiences that any of you have had that specifically relate to this. We had 2 employees who had issues related to children that were in daycare, and the daycares were closed. So we did make a decision to honor that under the Family First Coronavirus Response Act. At that time, not knowing specifically whether or not we had to, because there was a lot of confusion related to healthcare at that point being exempt. But in our case, we just decided that it was the right thing to do. So we did have 2 employees that went through the process with paperwork to qualify to be out on extended leave under the Family First Coronavirus Response Act. And it was specifically related to daycare issues. And I'm just curious if any of you had issues with this, either a similar situation or some other qualifying event under that act. And you can unmute yourself if you want to share anything.
Okay. Hi, this is Angie, and I'm from Western Pennsylvania, part of Genesis Medical Associates in and around Pittsburgh. And we definitely had issues like this pop up. And what we did was we were able to, because of telehealth, we were able to split our staff in 2 groups. And we had 2 groups of staff working from the office, 1 group working from the office, 1 group working from home. So the people working from home were able to do like our refills, our insurance authorizations, eligibility, things like that. And then the people working in the office were doing fax backs, handling the phones and stuff like that. And we were actually able to, that was our plan in case one of our teams went down, we would have 1 team in quarantine, 1 team that could still be seeing patients. But this helped a lot with our staff too, because then they had the ability to work from home and make those different kinds of adaptabilities with their families and everything that was going on. I actually had an extender, a nurse practitioner whose daycare closed down completely. So she went on the home team and just did facilities for, 12 weeks until her daycare opened back up. So we kind of anticipated that and just jumped in feet first.
That's great, Angie. Thanks for sharing that. And that's the kind of ability that organizations have and we're able to take to modify and allow people to work from home and break out into teams. So that's a creative way to handle it. I guess I should say that in our case, these 2 employees were both medical assistants. So for us, it was difficult to have them do their job from home. But we definitely had other staff, specifically some of our in-house billing department that was and continues to work from home just to reduce the number of people in the office. But thanks for sharing that.
Yeah, so we did send our MAs home also. They were my people working on refills. I would have 1 MA in the office to assist the physicians. And then we had 2 MAs that would work from home doing refills, because as a PCP office, you get hundreds of refills a week. It's crazy how much. And then they would do all of the insurance authorizations for all the CTs and all of that kind of stuff. So it can work. You just have to readapt your workflow in the office.
Thank you. Another topic that I'm interested in maybe hearing from the group is related to furloughs. I know in our situation, we did have to furlough about 2/3 of our staff, which equaled about 30 people. And that was an interesting challenge for me because I've never had to furlough that many people at one time, if ever. So in our case, it was a furlough for about a month, for mostly the month of April, from early April to early May. And then we brought people back in as we were getting telehealth up and running. We brought some of the staff back even sooner because we realized we needed them to help with the telehealth, which as Angie was maybe sharing, that the ability to have medical assistants perform telehealth, which could be done from home or in the office remotely while the doctors were working at home. So we definitely furloughed people. We had to do all the furlough notices and then the other notices to bring them back. And for the most part, it went smoothly. But we also, to this day, I'm still having some challenges with the Unemployment Compensation Office in terms of reports coming back indicating people are still receiving who have been back to work for several weeks now. And I'm communicating with them on that issue. So does anybody else have anything that maybe specifically relate to their experience with furloughs during the height of the pandemic?
I think you're not alone in that. I've talked to our HR department recently, and they're dealing with the same thing, the unemployment claims. I found it interesting. I helped staff our COVID testing site, and we called some people back from furlough to work specifically there. And I had several conversations with individuals who only wanted to work certain hours so they could still apply for the unemployment and get the $600. And, you know, so I worked through those conversations because I felt strongly that, you know, there was full-time work and they needed to come back and work full-time, and trying to work both sides of the system wasn't really something we should get involved in. So either work or, you know, continue to be furloughed. So, but I mean, I personally haven't dealt with, you know, the unemployment claims, but I'm sure I can't imagine.
Yeah, and I know what I've discovered with the unemployment conversation is George also alluded to yesterday. They are swamped. They're just overwhelmed with probably all of the processing that they need to do.
Right.
And I have communicated with them by email and by mail. It's virtually impossible by phone, I've discovered. So I feel like, well, I'm just trying to do what I can do to cover our bases to make sure I'm letting them know where I'm seeing inaccuracies. And I'm hoping at some point to hear back from them in a response. But I'll contact them when I get the report at the end of the month, and there'll be errors, and I communicate with them in the next month. It comes back and those same people are still on there. Anyone else have any issues with specifically furloughs or dealing with unemployment?
Yeah, actually, we had the opposite problem. We had people that we called back to work and had never received a check.
Yes.
And they were asking us to advocate for them. And we surely tried, but for all the limitations you just mentioned, it was very difficult, even as an employer, to get a hold of unemployment and say, you know, these people have been out of work for 6 weeks and they have not received $1. The other thing that really was an impact on morale was it seemed to us that there was no rhyme or reason who was getting the extra 600 and who was not.
Mm-hmm.
And I can't honestly say I still don't understand it, but that was a problem as well, is some people were getting it, other people were not.
Thanks for sharing that, Marianne. And we actually had that same challenge too, where there were at least 3 or 4 people who never received any of the unemployment compensation for weeks and weeks afterward. And same thing, they asked us to advocate on their behalf, and there really is only so much that you can do as the employer. You know, you're relying on this system, which is all, you know, mostly computerized, to be tracking where people have applied and when they've applied. And in some cases, we had to get local legislators involved to act on their behalf.
Exactly.
We have a minute left on this discussion.
Okay. Just to cap it off, I thought maybe if there are any comments that any of you have in terms of just when you look at your different situations in your practices now, what you see as far as impact in terms of hiring new employees now. Are you still in a hiring freeze? Are you at a point where things have resumed to somewhat normal, where you are hiring new people? I know in our case, we had a couple of people that decided to retire, so we had to replace them. And at least in one case, we had an employee who chose not to come back because she was concerned about working in the medical field. So we have hired new employees in the last couple of months. And, you know, I have projections where we may even need to hire a couple more people before the end of the year. I'm just curious if others have an outlook on that.
Yeah, we you know, we went through the furlough process like everyone else, and we cut our staffing levels pretty deeply. You know, during the height of COVID, when everything was really locked down. We've had a lot of people choose to retire. Some people with life situations, you know, kids at home that have chosen not to come back to work. And
Yeah.
So we have probably about 30 openings in my division alone right now, and we are having trouble filling those. And so one of the things that we're trying to do is examine our pay structures to make sure they're really competitive with our local market. And it's been a challenge. I think we're in more of a rural area than a lot of people. have had a lot of trouble trying to get staffed back to our, pre-COVID levels or even anywhere close to that, with everything that's happened.
Right. Thanks, John.
We didn't lay anyone off. We kept everyone employed. We had, I guess, one employee who didn't want to come in, and actually that's why I was late. I had to do an unemployment hearing for her because she didn't come back because she was afraid to work for COVID reasons, not because we laid her off. But we actually are increasing our staff. We're finding we need more staff to deal with COVID issues and to be able to safely get back up to the levels of patient volumes that we had prior to COVID. And we're having a difficult time hiring people. There's so much competition in our area. The hospital is really short on different staff positions, so they're recruiting heavily, and they're outbidding us sometimes for people once we get someone to say yes, and then they turn around and get another offer at a higher rate, and then they turn around and renege. So it is frustrating. Every time we think we're back up to where we need to be, then somebody doesn't come in or calls the day before they're supposed to start and says they're not coming in. So it's very time consuming and challenging right now in this environment to keep the staff that you have at the level you need.
Thanks, Kathleen. Well, very interesting. Thank you all for sharing. I think I'm probably just about out of time for my section, but I really appreciate everybody's perspective and just sharing of your experiences with it. And of course, wish all of you continued success as your practices recover.
Thank you, Paul. I appreciate you moderating that discussion. Our next topic will be telehealth, and our moderator is Holly Dieter from the Evangelical Community Hospital. Holly?
Good morning, everybody. As far as telehealth, just to tell you a little bit about our experience, we were not utilizing telehealth prior to COVID. And as we've already talked about throughout this conference, and Paul, you alluded to that, it was almost a necessity. So I think in a matter of probably a week and a half, we were able to enroll telehealth into our practices. That we met, some challenges with that. Some of our staff were not well in tune to the electronic side of virtual meetings, so to speak. But we've worked through it, and I'm just curious to see we're to the point now of looking at how do we expand telehealth and where is that going to sit in our long-term strategy. So I would ask, what are your plans for telehealth as we move forward here in the COVID process?
I can just say we are doing not so many video telehealth visits because we're finding patients decline the video piece, but as long as we'll do it via phone and those are still covered, we're doing a lot of those in my urology practice. That's really the only thing that's keeping us afloat, to be able to do those phone visits. So we're hoping that will continue past January. And I don't know what we'll do if they discontinue those. The internet connectivity around here, which you've probably found that maybe as well, Holly, is just not as robust. And so that's provided some challenges.
We found mostly with our elderly population is where some of our struggles been, but then we've been educating the elderly individuals to say, do you have a son or a daughter that perhaps we could connect through them and they could be with you during the appointment? And we've had some success with that. Honestly, back to what Paul was talking about with staffing, we're struggling with keeping our volumes of staff up. And so it does take time to set up the televideo conference calls. So we're probably not doing as good of a job as we could be with helping our patients embrace the televideo. As you move forward, Tracy, are you thinking of other opportunities? Have you identified any areas other than just, our seeing a patient in the office model? Are there any services that you're looking to expand telehealth to? Or John, maybe you could answer that as well.
I think that we found that certain specialties work much better with telehealth than others. So one of my specialties that I manage is cardiology. The cardiologists themselves were very resistant to telehealth. They wanted patients to come in. You know, you can't listen to a patient's heart through the computer. And that did lead us down the road of starting to implement some remote monitoring technology, which has been good for patient engagement. That's one of the things that I'll talk about during the patient engagement piece. We found that, you know, follow-up visits for things like sleep medicine, specialties like endocrinology and allergy, those are probably some of our bigger specialties where I think even once we get out of, you know, kind of the heat of COVID, we will really try to continue to implement and, you know, use telehealth to engage patients. I mean, it is ultimately more convenient. Patients don't have to come in. And if it allows us to better utilize our space, then, you know, we're all for it. I think, you know, most of the people on this call are probably waiting to see what things look like when COVID's over in terms of payer models. You know, our payer is going to start to reimburse less for telehealth visits. You know, right now it's great. You know, we have a good crosswalk to, you know, normal office-based E&M visits. But, you know, I think a lot of the future is really going to depend on what payment models look like.
Anybody else want to share?
Hi, this is David. One thing that we're kind of wrestling with is people that have chronic conditions is what's the mix of in-person and telehealth visits. So you have a diabetic who's stable or a hypertensive who's stable. Doctors often see them 3 to 4 times a year, but all those visits probably don't need to be in person, but probably at least one, if not more, should be. So I think we're just trying to figure out what makes sense medically, and can we build that into the expectation of patients and say, you know, we'll listen to your heart and your lungs, you know, in December, but the rest of the time, get your lab work done and check in, and we can manage you well on a, you know, telehealth basis. So, so it's part of, you know, I think us refining how we use this tool.
Yeah, I would agree. I would think we're looking obviously more to our established patients and certain testing. You know, we're urologists, and you know, we realized that we could send the packages out. We use couriers for other things, and it was just an easy next step to send packages to our patients and then have couriers pick them up and bring them into our lab. So it really is about thinking very differently about the testing that we do and the services that we provide. And I would agree with my peers, and it's really going to depend on what the reimbursement looks like post-COVID.
Is anybody in primary care, and are you looking at how you're going to treat your respiratory patients as we move forward when they have COVID and flu resembling each other so closely?
This is Sharon. I'm in primary care. The doctors talked about doing a telehealth visit and giving like Tamiflu and then having them COVID tested so that they can sort which one they're having the symptoms for.
That's similar to what we have planned as well. Is anybody using the electronic stethoscopes or EKG remote with their patients? Pulse ox? Any pieces of equipment like that? And if so, could you share your experience?
I just started using, this is Angie from Pittsburgh. I just started using remote patient monitoring with scales and blood pressure cuffs for my patients. I haven't heard about the electronic stethoscope or EKG machines, but so far we are using these scales, and we're using them in our facilities and stuff like that too, like our assisted living. And it seems to be working really well, because then we're getting some data on these patients to make changes with their medications and such.
Anybody else like to share, or do you have any questions that you'd want to ask of our participants?
Oh, I'm sorry, I was on mute. Did you guys hear me about the remote patient monitoring?
Yeah.
Yes.
Okay, all right.
Yeah.
My computer's being weird.
I was going to say, Holly, can you provide information about the electronic stethoscope you were talking about?
Can you repeat that, Peter? Your voice is very faint.
Sorry, can you talk about the electronic stethoscope that you were referring to?
Sure. It's about $125, and you essentially can have somebody out in the home. Like you could do a hospital home paramedic go out, or you could have what we call our CHOWs, community aid assistants, that they can go out and actually lay the stethoscope on the patient, and then the physician can actually hear what the heart sounds are like. And there's a part of that you can also get an EKG reading electronically through. There's certain kinds of stethoscopes. We have different models, and we actually are not utilizing them in ECH at this point. We're using them for prison work in our prisons, and we're using them through our ACO that we participate with.
And we're within a minute, Holly, just so you know.
Okay. So just to wrap up, does anybody want to share any further challenges they might be having, or any strategies they may be thinking of as they move forward? No.
Biggest challenge is that our organization mandated that we use the telehealth module that is built through our Meditech portal. And so we have a lot of patients who don't want to sign up for the portal, but they're open to doing telehealth. So I guess I'd be interested to know, I mean, is anybody using something like Microsoft Teams, where it's really just kind of a web-based system, or, you download the app versus having to have people actually sign up for a portal? Have you had better experiences with that than you would think in terms of portal enrollment?
I don't, but I'd be interested in that answer too.
Does anybody like to share?
I'm sorry, the volume was cutting in and out. Were you asking what other platforms people are using for telehealth?
Yeah, I guess what platforms people are using, and then also, is it a platform that's directly integrated with your EHR, or is it, a third-party platform that has a little bit lower barrier to entry for patients to use?
Sorry, I didn't catch any of that, but we're using, sorry, I'm with Genesis Medical. We're using Doxy. It's doxy.me. It's not integrated in our EHR, but we were able to get integrated or get set up with them very quickly when COVID hit. We had a 24 to 48 hour turnaround, and we were using them.
In our case, when we first started, we did not have any connection through our EMR, which is Nextech. So we also were using DoxyMe and Doximity. But within probably 2 to 2.5 weeks, our EMR vendor, and I give them credit, they really moved fast to implement changes to the EMR to allow the visit to happen right within the EMR. And by sending a link to the patient, they would be able to be linked right into Nextech. And that made a huge difference just in terms of efficiency. And so going forward, we've been using that connection, that direct connection into our EMR rather than Doxy or Doximity. But they tend to be the fallbacks if for some reason the connection goes down.
Don, we've been using Microsoft Teams from day one, and unfortunately it doesn't integrate into the EHR. So it's a lot of legwork in the beginning to get that set up and test with the patient. And then the provider's doing a note just like they're in front of them, obviously, in the EHR. Okay, well, thank you all very much. Peter, I know I went over a minute, but my apologies.
That's okay, don't worry. Thank you, Holly, for moderating the telehealth. Our next subject will be the financial impact of the pandemic. We have 2 moderators for this one, David Regan, who is with WellSpan Medical Group, and Marianne Thompson with Academic Urology of Pennsylvania. So David and Marianne.
Well, thanks everybody. Marianne and I really didn't have a chance to rehearse. So Marianne, I'd like to let you go first, and then I can jump in because I have some notes and thoughts.
Sure. So what I thought when I think about the financial impact of COVID, I kind of separate it into 3 separate categories, and that's sort of how I'm going to share with you how it impacted us. We covered a little bit in the staffing portion of it. Some of the funding that was made available made it very difficult to operate because our staff was much rather interested in staying home and collecting more money rather than coming to work. And so that has adversely added to our bottom line. Our bottom line, we virtually shut down as a specialty practice. We were put out of the hospitals almost immediately, appropriately, early on in March. So we lost that revenue stream immediately. And then we have our own ASCs. We have 6 of them. And then, shortly thereafter, they were also told to shut down, except for emergent care, because we were preserving PPE for the hospitals. So there were 2 streams that closed down. And so then the last thing we had was office visits. So we probably continued to see patients in the office maybe till mid-April. But we made a quick conversion like everyone else to telehealth, because by then, after, I would say we actually even almost shut down the last 2 weeks of March. It was actually, from a financial perspective, kind of frightening because you just didn't know. This is just unheard of in healthcare. The one thing we always have is a steady revenue stream because we always have patients. So, so we lost those. We had those lines of revenue shut down, and then the third portion of it was the influx of funds from all of the varying funding agencies. We had the HHS money being given to us. We had the Medicare money being given to us. We were able to apply for, the payroll protection funds. Here we went and, I went full Monty. We got all the funds that we could, and managing that has become, its own nightmare. We don't know from day to day what we qualify for in forgiveness, what we don't. And so it's been a challenging time for financial people, given all of those different tranches of information and changes. The changes were just like a tidal wave. So that's been my experience. We're now, we're just closing that 3rd quarter, and we're trying to make some projections going into year end. I think May and June for us was probably the worst. You have that lag of billing. And as of today, our offices are open. We're having difficulty getting back up to 100% because of the staffing issues. So the financial impact just changes. We're focusing on forgiveness. How do we deal with that? And so there, COVID had just such a tremendous financial impact on the practice. I never would have thought that my work got 10 times busier when we weren't doing any work, but that would be my tagline, that, the financial department got hit probably equally as hard as anybody else. David?
Yeah, so the system I work for is WellSpan Health in Central Pennsylvania. So it's the medical group is large and multi-specialty. So our specialty practices were hit the hardest, generally speaking, because ASCs and hospitals were shutting down all elective procedures, and that's where we had most of our furloughs and our biggest financial drops. In the primary care world, we did see volume decreases, but we're able to rebound those sort of midstream, if you will, of the bounce back or the recovery, thanks to telehealth. And we were lucky; our patients embraced it pretty well. The question we're not sure now is if they'll continue to embrace it now that they have the option of actually coming back into the office or not. But patients were generally loyal, and all the economics that come with furloughing and revenue streams, especially profitable ones like the procedural work, in practices being shut down. I think our system did also take advantage of those programs where we could, get financial assistance. And luckily, I'm spoiled in that I don't have to deal with reconciling all that when we to know when it's totally forgiven. But that definitely helped carry the day, when in the darkest days. If you looked at our financial performance, it was a classic V-shaped dip. And so, beginning in March, it, plummeted downward. And then, it started climbing back up around May. And then depending whether you include or exclude the support dollars that we've gotten from various federal or state programs, we're pretty much back to our performance where we were pre-COVID without counting those support dollars in July. So we overall were feeling not too bad, happy that we got back there. Although you dig a little deeper, it's interesting, our proceduralist practices and our specialty practices are actually beating prior year's numbers. So I think they're still in a catch-up mode, at least that's our read of the data. And our primary care practices are not quite there. They're about 96% back. So there seems to, maybe it's because of the summer or whatever, but it seems like we haven't had a full recovery in the primary care world. So it definitely, the impact and the timing of the recovery was varied by the specialty. We had one specialty that had almost no dip at all, which is not, when I tell you the specialty is not a complete surprise, but then you kind of think, well, how come others got impacted? And it was our neurosurgery practice. They didn't miss a beat. And I guess partly because by the time you're getting your brain operated on, you're committed and you have something serious enough that COVID is only one of a small many things to worry besides your surgery. Or else you're in a pain position where you're going to let someone operate on your spine. And again, those patients are committed and work through the process to become eligible for surgery. So that's interesting. But we saw dips in hematology, and you would think, gee, if you had cancer, you'd take that serious too. So the psychology of when patients deferred or not is probably will make for an interesting study by someone. I don't think I'm going to be taking it up, but I thought it was very interesting. The one thing is, I wrote down my notes about what to talk about is, the past is interesting. I think we can learn from that. But, really, what are we doing and how are we managing in the go forward mode? I've heard discussions about staffing the office being a challenge in some locations. We have that challenge as well in some areas. And be interested in hearing what people are doing really to get back up to where they think they're supposed to be in this new world order.
Reminder, please unmute yourself to participate.
Thanks.
Go ahead,
Mary Ann and David, I just would share that to answer the question about where we are now. We have resumed having mostly in-office visits. Telehealth is still an option, but in dermatology, it's very often that even if the physician has that telehealth visit, that if they want to perform a biopsy to be sure of a diagnosis, they're going to need the patients to come into the office. So we are returning patients to the office and more or less have since the middle of May. But the change that we have made is that we have less doctors working in the office each day. And we have developed a system that more or less reduces the number of people in the waiting room to really just one or two, maybe three people. We've set it up so that people basically can come right in, right from their cars and check in with the goal of obviously trying to maintain that social distancing. And the other feature that we continue to do is screen all of the patients. When they come in, we have an additional staff person that both takes their temperature and asks them a series of questions to basically screen them before they would come in any further into the office. And I'm curious as to others, if you're practices are doing that, where you still have somebody screening, because based on just conversations I have, some practices are still doing that and others are not.
In my urology and general surgery practices, because we're in the same building, we share a common waiting room. We're screening at reception, but saying that, we have plexiglass windows there that open and close. So we open it just a little bit, and the staff member is wearing a mask and shield. They ask the patient all of the questions first, and then we open it just enough to scan a temperature. And we're doing the same thing, trying to keep people out of the waiting room. And they're limited to only one visitor that can attend with them. During the height of COVID, we had building screeners, and we were screening people even before they got into the building. But we just don't have the staff bandwidth to allocate someone to sit out, in the waiting room even to do that. So we've had to make that change. Now, I know John at 1850, they have building screeners, and they're kind of sharing it across all the practices that are there, but I know that's been a challenge for them as well.
So over here, we're very close to the city of Philadelphia. We're located in the 5 surrounding county areas, and we really have not moved far from that original model where most of our all of our patients still are checking in virtually, and they're waiting in their cars. And to your point, I just don't foresee that changing in the near future. And so our future is very different than our past. Like you just can't see the same number of patients when you're doing these kinds of things. And we're rethinking, as a practice, if we were a practice that saw X amount of patients, we're going to now see Y amount of patients. And we just don't see that changing anytime soon. And it's hard because there are patients that need to be seen. And so the doctors worry more about the care of the patient. Certainly they're interested in their financial outcomes, but even though we're coming back up, that V that David, you talked about, we haven't filled that bucket yet. We are ahead of the same time last year because we're trying to see more patients. They're doing longer hours. We're picking up Saturdays. We usually don't. But I don't see where we're going to fill that bucket. And under the current methodology, where we do need to be so careful in cleaning rooms, we're going to be able to change that.
We have the same problem here in urology, but our problem was kind of compounded on top of COVID. We lost 2 full-time urologists in the area. So we went from 5.6 urologists covering our, I guess it's 6 county region, to only 3.6. And we're receiving 50 to 90 new patient requests every week, and we can't keep up. And it was difficult to keep up with all the patients we had, let alone get all those new patients. So we're actually triaging every new patient request that comes in, and to try and ensure that we're giving our attention to those most needing the care.
Mm-hmm.
That's kind of on top of COVID. That just additionally complicates everything for us.
Sure.
Coming to the end of did somebody want to say something? Go ahead.
I was just going to say what we're doing in our practice is we're pre-screening the patients by doing everything possible. The MAs are calling the patients ahead of time to do most of their visit over the phone. So they do their med rec, their family history, their social history, everything over the phone, pre-fill the EMR with that, so that when they come in, they just have to go back and get their blood pressure and pretty much then the doctor can see them. So we're limiting the time that the MAs spend with them. And we do pre-screen over the phone to make sure that they don't have any COVID symptoms or have anything like that. And we ask them if they're sick not to come in. And then of course, when they come in, we do take their temperature, but we have a temperature gauge at their front door that they can just take themselves, and a sign saying that if it's a certain amount that they're supposed to call us and not come in. We can't have staff. We don't have any staff to kind of sit there and do that at the entrance of our building.
Mm-hmm. Yeah, I would say that what I've heard through this financial session is the effect that the lack of staff and lack of resources will have on our bottom line equally as much as the virus itself. The outcome, you know, the fallout of not having enough staff will probably have the biggest impact on our ability to recoup anything going forward. We're going to have to change how we do things.
Thank you, Mary Ann and David, for leading the session. I'm not trying to cut it short. I'm just watching time. But it's interesting to hear all the dynamics, and I appreciate everybody's participation. Our fourth topic is patient engagement, and it'll be led by Jonathan Rose of Mount Nittany Physician Group. Jonathan?
So I dialed in with my phone, so I hope everybody can hear me a little bit better now. So patient engagement is obviously a pretty loaded topic in the world that we live in these days. You know, and we all, you know, nobody could prepare for the changes that we, you know, encountered in the, you know, March, April timeframe with COVID. So I guess really, you know, to start this off, I'd be interested to know, you know, what people's orientations towards patient engagement were pre-COVID, and then how quickly were you able to make changes during COVID, especially during that really acute phase when everything was locked down, and then how much of that you implemented during that acute phase have you continued versus being able to get back to, you know, where you were beforehand in terms of a more normal operating state?
I can start just by sharing that for us, and I'm sure this is true for everyone, was the use of telehealth and getting patients to engage with their providers through, initially in some cases it might have been laptops, but we found it was more effective if they were using their phones. And that was, that brought its own challenges based, I think in some cases on the age of patients and their familiarity and ease of using their iPhone. You know, I just as a quick kind of almost, you know, humorous, I remember one day walking in, I overheard a doctor was having a telehealth visit, and I heard the doctor say, no, that you're looking at the ceiling. I need you to move the phone down. No, now it's pointed at the floor. And, you know, so that was certainly a challenge, trying to get patients to feel comfortable with using their phone to interact with their doctor, especially when they were trying to, you know, pinpoint a rash maybe on somewhere on their body and just not being familiar with it. But as time went on, we got more and more patients comfortable with it. And so that's one experience that I'll share.
So Paul, I would agree. We're in urology, we have primarily senior citizens, and our doctors so they were just so happy to get a phone call that a typical office visit was doubled and tripled because the doctors didn't know how to get them off the phone. And the wives were typically holding the phone, and then the wives would take over the visit and would start answering for the husband. So we had a terrific learning curve at the beginning to actually see our patients and not the patients' wives. And we had to coach our doctors how to get off the phone, because senior citizens, they would have talked all day if they could.
Yeah, and I think that's a really interesting point. You know, I think that we saw something very similar where, you know, I realized that we were there for much more than just providing, you know, cardiology care to a patient. You know, it's really,
Right.
an emotional and kind of social support structure. And we did have patients who were really eager to get back into the office. The day that we were able to have in-office appointments again, our schedules were packed, and they have still been packed since then. But it was interesting to really see that it was more than just their acute issues or their chronic cardiac issues that they were really calling about. And we did see the same thing with an increased duration of time that patients wanted to stay on the phone.
Yeah.
In terms of engagement, some of the things when things were locked down, programs had to change. So, our cardiac rehab program is a hospital-based program. And obviously, at the height of the lockdown, we didn't want patients who didn't need to be going to the hospital. But, cardiac rehab is obviously, an acute thing that needs to be done in a timely manner for patients to really get the benefit from it. So, I have an interventional cardiologist and his PA who came up with a really creative solution to leverage telehealth. And they actually implemented and designed within about a week a home-based cardiac rehab program where they would have a telehealth visit with somebody, they would go over exercises, and then they would check in about every 2 weeks. And I think from a patient engagement standpoint, and I know that's a very specific example, was anybody able to develop or implement programs they were able to quickly pivot from an in-person setting to a telehealth setting that they found that were effective? And have you continued any of those programs if you were able to do that?
John, this is David. I'll repeat this secondhand because I was not involved, but in our system, our physical therapy departments responded very quickly. And how can patients replicate some or all of their therapies at home? And so, maybe that meant sending them the stretchy bands or things like that. So they felt that was very successful, and they believe a significant portion of their practice, perhaps after the initial consult, will be done at home or, be in some virtual mode. They saw that as something likely to stick. So I know that's one place where we recognize we had some real jump ahead in how we were using that technology. I think the other thing that WellSpan learned is we had for some time been really pushing our patient portal, partly as a strategy to enhance engagement with patients, partly, quite frankly, as a labor reduction process. So to the degree that we could get patients to use our portal to look up their lab results, schedule appointments, ask for prescription refills, that meant more phone calls that we did not have to hire staff to answer in the practice. And based on that, we use that as a vehicle also for our virtual visits. And so for a lot of our patients, it was kind of automatic. They were already set up. They didn't have to figure out setting up an account and a password, all that. So because it was not new for everyone, I think that helped help advance the use of the virtual visits. And we're still pushing that and adding capabilities to that.
Thanks for sharing that, David. Does anybody else have examples of, either portal engagement or, any other programs they were able to pivot? So one of the things that we actually have had a lot of success with, and I think it's actually brought new patients into our system, is Facebook Live events. So our chief medical officer for our health system is an infectious disease doctor by training, and he started having weekly events on Facebook Live where he would talk about, general issues with the pandemic and then some more specific things to our health system and, what we were offering and how we could do them. And, at least according to our communications and marketing team, those Facebook Live events have, generated hundreds of thousands of views. Which for a health system our size is pretty impressive if those numbers are accurate. Has anybody done anything, from a social media perspective to try to, reach out to either your existing patients or to, just the wider local or kind of regional audience, that are potential patients to you?
We started using, which we've never done before, is we started sending maybe bi-weekly updates through Constant Contact, letting our patients know as we were coming closer to reopening and telling them how we were going to reopen, the steps we were taking. And that's not something we typically do. Generally speaking, we don't reach out to them. And we got favorable feedback.
We sent updates and just general information out to our patients through our patient portal. That didn't reach the whole community, obviously. It would just be the patients that were participating, but it was much appreciated. We got several comments about that.
Jonathan, we're in a 2-minute warning, just so you know.
Okay. So I guess, you know, were there initiatives that people tried, you know, that were well intended and that they thought would work that just really kind of fell flat, you know, that you had to go back to the drawing board, you know, or things that really worked during the short term with this that, you know, you don't think will carry forward? You know, it might save some people some time if they're thinking that that's, you know, going to be the thing that gets them through this, you know, but somebody's tried it and it has not worked as well as they expected.
In my specialty practices, and I'm sure I think Holly's offices did this as well, but we began to sort of do more of a pre-registration over the phone when we were screening and doing their appointments. So it really, you know, we've always sort of talked about doing that, but it kind of pushed us into that because we wanted to have the patient in the office the least amount of time possible. And we've continued that as we've gone back into our regular schedule. We now do as much over the phone before they come in order to just keep the day moving, which keeps the provider on time and just, you know, you don't get that bogged down at check-in and have the line and all of that. So it totally changed our workflow and we kept it, you know, it's working really well.
I guess that leads me to one other question that's been a big point of discussion here at Mount Nittany that kind of, you know, goes more with the financial topic that we talked about. How many people are collecting copays right now in person versus, you know, only through some kind of an online portal, or, you know, are places that, you know, doing zero copays at this point where, you know, everything is getting billed out?
We're
still collecting copays, but strongly encouraging most people to just do it by credit card. That was something that, I mean, we've always had that for years, but when there was a lot of concern about whether this virus was being contracted also through touch, you know, we said any touch points that we can reduce, which is, you know, touching cash. We really encouraged people to pay by credit card.
We're using a system where the patient, they can either pay when we do the scheduling up front, when we call them with registration, we accept payment over the phone in advance of them coming in, which helps them to come in. And then they get a link as soon as they check out. Our system sends them a link saying, thanks for coming to see us today. You can click here and pay your bill via credit card.
Thank you. Peter, I think that we're probably at time.
Well, thank you, John, for moderating that session. I want to thank again all of our moderators. So Paul Brewer, Holly Dieter, David Regan, Marianne Thompson, and Jonathan Rose for leading the session. I want to remind you of a few things before you all depart, and I know it's 12:30, so I will keep this as brief as possible. One, please make sure that whether you're using your mobile device or using the laptop, visit the exhibit hall, and do thank all of our sponsors and exhibitors who have participated there. If you haven't gone to the exhibit hall, it looks really crowded. I don't know if you can see, everybody is in there, so, but I don't see you people in there. So I need to make sure that you go in there and talk to our exhibitors, but more importantly, thank them for the support. You know, they're going through a rough time as we are too, and they're trying to figure out, you know, what dollars they have where to spend. And we do appreciate that they have stuck with us through a virtual conference, which is by no means the same thing as an in-person conference and the kind of dialogues and networking that takes place. So please make sure you see them. Also on the Socio app is our event game, and there are some very interesting questions. And for those of you who participated today and paid attention to my initial introductions, I gave you a little bit of a clue as to one of the answers to what is otherwise a difficult question, and probably for many on this call. So I'm not going to tell you what that is. You had to pay attention. So go to the event game and participate. I also want to remind you, if you have your own social media account, or if your practice has a social media account, if on the mobile device, again, if you go to the second page, you'll see it says follow us. Follow us. And in that, if you click on that icon, you will see the links to our specific social media pages. So for you as a professional, please make sure that you join us. And if your practices, make sure that they join or follow us as well. The links are right there. I also want to remind you that recordings will be made of each of the sessions and available only to virtual conference registrants. You will receive information as that comes available. And last but not least, we are a fun group. We always have been and we always will be. Tonight at 5 o'clock is our virtual happy hour. You know as much, we need a little breather. We need a little bit of break from being confined within the walls, not just of either of our practice, if we're able to go to work, but even of our homes. Or some hybrid thereof. So please join us at 5 p.m. tonight. Bring your favorite beverage, whatever it is. You can call it water. It could look like water. It doesn't have to be water. And come and join us and let's have a little bit of fun. If you haven't selected that already, go to your Socio app. Make sure that you click on agenda, scroll down for today's agenda, and where it has a plus sign next to happy hour at 5 o'clock, make sure you check it. I did. I'm going to be attending. And I think I'm going to have a bottle, actually, not just a glass. So for the rest of you, I hope you do enjoy, and let's bring some camaraderie to this environment that we're working in right now and through this pandemic. For those of you who are non-members, I encourage you to become members of the Pennsylvania MGMA. Our membership dues are $125 on a rolling 12 months. So if you were to join today, you're good through this time next year and be able to receive the benefits of membership, including monthly collaborative webinars, our newsletters, 6 newsletters, access to practice resources, and a slew of other benefits. Most importantly, the networking and the camaraderie and the sharing of information as we did today. So on behalf of the Pennsylvania MGMA Board of Directors, thank you to all of you, and thanks to our sponsor for this session, Curtis Bay Medical Waste Services. I look forward to seeing you all at 5 o'clock today, cup, bottle, or drink in hand. And don't just smile because you know you want to participate. So make sure you check it off on your agenda, and I'll see you all at 5 o'clock. Thank you, everybody.
Thank you, Peter.
Thank you, Peter.
Thanks, Peter.
Bye.